Okay, so thank you, and now is the time for something new. This talk is going to be a bit longer because it's going to deal with concepts that are totally new for you. And I am the medical director of ALIO, so I am talking about a technology that we have been studying for now 18 years. First question is, can we restore accommodation, this complex mechanism that was described and probably is the only one true mechanism of accommodation by bone health so far away? Probably yes and no. And let me tell you why. In the past, we learned that we had many mistakes. I mean, many mistakes made us to decide and to choose some lenses because they were accommodating where they were not true, because the methodology for the studies about these lenses was poor, because there was a commercial bias, and the monitorization of the investigation was poor. Actually, the near vision tests were seen at 70 centimeters, which is not, as you know, the near vision testing on regular optometric basis. So the past tell us that we did mistakes, and this is a study that we published independently from the companies in which we demonstrated that these lenses were no different than a monofocal lens, as you can see here in this image, and only the crystallis for intermediate was a bit better because this lens had a 1+ near vision at the center, so it was similar to the AIOS that we have today. So we summarized everything that was so much disappointed about lenses in this paper that we published now almost 10 years ago, and this was a desperate moment in which accommodation was not easy to accomplish. Let me remember to you how we can change the power of the eye according to distance. We have only three approaches: either to change in axial position, angle with a single or dual optic, either to change in shape or curvature, or change in refractive index or power. Only these three mechanisms can change the power of the eye according to distance. And the second issue is how can we get the lens in the eye? Should be inside the bag or outside the bag? And let me explain to you why some of these lenses in the past failed. The capsular bag is a basal membrane of a lens epithelium, and one that is empty. There are no functions and no anatomical reasons to exist. Fibrosis and atrophy are going to follow, and the capsular bag theoretically cannot function in the long term when it is empty from its content. This was published by us in 2015, and we demonstrated in an experiment I'm going to show to you what happened. The experiment was in the old monkey, in which we implanted a measuring device either in the sulcus or inside the capsular bag when these monkeys were at the age of 9. 9 is when they are about 30 years of age, equivalent to a human being. And this is the measuring device, and we stimulated the ciliary body either pharmacologically with pilocarpine or by direct stimulation of the ethical westphal nucleus. In any case, we could see that after 3 months, and especially after 5 months, there was no energy and no movement of this device when implanted in the bag, while even 2 years later, these forces were detected when the lens was implanted in the sulcus. So in this paper that is published in this reference, we saw in 2005 that the capsular bag was a wrong location for accommodative lens, and the forces generated at the sonular anterior capsule system are the ones that probably should be used for accommodation. Based on that, several models were designed, and finally the Lumina appeared. The Lumina is a dual optic lens in which two varifocal surfaces, one is sliding onto the other, creates a continuous change in the power of the eye according to distance. This is based on the Alvarez principle. Alvarez received the Nobel Prize in 1953, 72 years ago, and was the basis of all the autorefractometers that we have today. So this is the lens. The lens is implanted in the sulcus. The lens functions independently from the capsular bag, and the lens is working in the way that you would see in this animation. You see that the lens is moving in the frontal plane. This frontal plane is according to the forces transmitted to the haptics in the ciliary body, and this is the way in which these two varifocal lenses act as it happens in real accommodation, in which when the ciliary body is contracted, then the power is increased according to distance, and when it's released, the power is decreased according to distance. In other words, we have a monofocal focusing depending on the distance and not creating any multifocality. So this is the way in which the lens is implanted. As you see, the haptics are perfectly embracing the ciliary body, and the ciliary body, when it's contracted, pulls in the frontal plane one of the haptics onto the other, and in this way, the Lumina changes the power according to ciliary body action. So we had 3 studies: a phase 1 safety study that was performed in Alicante and in Fyodorov Institute, phase 2-3 well performed in Bulgaria and in Vision and in Alicante. I was sorted in all these stages, and I'm going to show to you the latest design, which is the phase 3 study that has just been accepted for publication in Journal of Refractive Surgery. This is the lens, how it is implanted, and as you will see, we always implant the 180 meridian. The 180 meridian is selected because the lens is measured with high efficient methods in order to be customized for this for this location. There is no toric model of the lumina so far, and the capsular size is independent from the result. This is the lens that should be implanted in the right position. If you implant it upside down, the lens doesn't work and creates the refractive imbalance. The lens is introduced in the injector. It's a regular injector that goes through 2.75 incision, and the injector can be used either monomanual or bimanual. It depends on what would you like to do. And the lens is, and this Medicel injector can be used as any other injector that you have in your practice. The lens, once that is inside the eye, has to be implanted, collapsing the anterior capsular back onto the posterior. We use cohesive viscoelastic for the purpose, and then we open to 2.75 to 3. The tip of the injector is introduced in the anterior chamber, and the distal haptic is introduced in the sulcus with a movement that you have with the second hand. You push the trial haptic into the sulcus as well, and you verify that the lens is rightly implanted by the circularity of the capsular ring. This is the simple surgery that we need, and then the viscoelastic has to be removed. As you see here, these are the results. The results show that 81% of the patients had uncorrected visual acuity of more than 0.7 or more, and 100% was with best corrected for distance visual acuity when corrected in all cases. In uncorrected for distance visual acuity, we had, 91% of the cases with the level of J1, and as you see, the best corrected for distance visual acuity in 100% of the cases was 0.8 or more. So this lens was working well for far and working well for near in phase 3 study. As you see, the patients in 88% of the cases could see even small characters with check invoices, and far vision was good, with good satisfaction from preferred for the patient watching TV. 100% of the patients raised vision, 7/10 in patient-reported outcomes analysis, and there is no change in the conservative function as expected from monofocal lens, and there is no or minimal faulty phenomena as studied with the halometer of size. This is the demonstration that the lens accommodates. This is the graphic in which you see the change in power of the eye according to distance and demonstrates accommodation. As any physiological function that is recovered, you have a variability, and this variability reflects exactly what is accommodation. 75 of the eyes had a focus of 2.5 to 3 diopters at a visual acuity of 20/40 logMAR or better, and what means that we have some variability. The patients accomplish all of them good intermediate vision, some of them very good near vision, and most of them have intermediate to near vision accomplished with spectacle independence. This is very important and demonstrates that the eye has this variability in the defocus score. According to the study, we have a 12 and 24 months equivalent results. So there is no decay in time according to the diopter gain in near vision, and capsulotomy doesn't affect the outcome of the lens, but rather increases the accommodation as well. If you have a capsular back disruption, bad news, you have the good news that the lens can be implanted in the sulcus, and look here in this case that we have 1.9 diopters of increase in power according to distance in this patient that had posterior capsular disruption. This is remarkable, and this lens can be used in those cases in which you have a problem in the operating room. We have analyzed and described a method to study retinal function with different intraocular lenses. These are retinal clinical function, and in this eye, you see that the accommodative lenses behave identical to a monofocal spherical as expected. This is important, and just to show to you the difference, this is a well-known EDOF lens that have not always so good quality retinal image. This is actually one of the worst, and this is the mini-well, while the monofocal of Alcon S660 shows this image, while with the lumina you see here that you have a swirl ratio that is slightly less than the monofocal, but is basically almost identical to the monofocal as well. So which are the pros and cons of this accommodative lens? I have to tell you that the accommodation that we gain is not exactly the one that we have in the defocus scope. This is why I call this lens accommodative plus, because we have some short accommodation as well that still not been unveiled how it happens. The pros is that we have consistent near vision outcomes with excellent far vision, no division of light, and no aberrated and with no conductivity loss. Long-term demonstrates tolerance to sulcus implantation. We are already with more than 10 years follow-up in the phase 1 study. There's a consistent phase 3 clinical investigation, which has been published, a thread of publication last month, and this is an absence of long-term, more than 14 years complications. On the contrary, we have a frequent PCO that due to poor opposition of the obstetrical sulci, so you should expect to perform JAGLIS in these patients before 6 months in at least 30% of them. And there's a disparity between the focus scope and accommodative gain. This is why I tell you this is an accommodative plus lens. Not all what we gain for near comes because change in power. And this is remarkable. We don't know. We have been unable to know why we have extended depth of field effect with this lens. Some cases of iris pigmentary epithelium changes, but there is no pigmentary dispersion, probably because the surgery initially was more traumatic. So this is an ideal choice for irregular or highly aberrated corneas that are not selected for trifocal lenses, for instance, as we just mentioned. And you can read the outcomes of these studies in American Journal of Ophthalmology was the first paper, Journal of Refractive Surgery, second paper, and the third paper has been accepted for publication in Journal of Refractive Surgery in February 14th of this very year, 2025. You can read a full chapter about accommodative lenses and especially the Lumina in this third edition of our book that we will release in September 2025 with the name Multifocal Intraocular Lenses there and the practice. And we have one lesson in our online course with 500 hours of teaching activities online in English with multimedia offers about accommodative lenses as well as in other intraocular lenses and corneal, cataract, and refractive surgery. And I thank you very much for your very kind attention.
Okay, thank you. Actually, if there's any quick questions, we may actually have a few minutes before we go on to the last two talks, but we can ask Robert to come on up and get set up. Obviously, this is kind of like the holy grail of presbyopia correction, is if we can actually get restoration of accommodation, that would be the way to go. And if we can do it with an IOL, then it takes care of cataract and everything in the future as well. I guess even with your experience, because you have looked at a lot of different models, what will it take to really come up with the ultimate accommodating IOL?
This is the lens, because the intracapsular lenses will not work. Believe me, will not work. And look at the different presentations in the past with different lenses. I'm not going to mention them that were implanted in the capsular bag. You cannot listen a single presentation in this meeting or the American meetings. They have disappeared because the outcomes were poor. This lens has been for 14 years investigated. We have an animal model, is working, and the only one problem is that we have to change the paradigm. So far, we were implanted lenses in the capsular bag. Now we have to implant this lens in the sulcus because the accommodative forces are in the ciliary body, not in the capsular bag. And so the resistance to the adoption of this lens will come because the change in the paradigm that we have in our computer about whether the lens is the crystalline lens bag is the one in which the lens should be placed. It's not. And accommodative lenses, once that they are generalized, and obviously we need multicentrical studies to really verify everything that we have said. Science has to be repeatable. Once that this is repeatable, in my opinion, everybody will embrace this because we have no neuroadaptation, no dysphotopsia, no problems in selecting the patients. You can choose an aberrated cornea with good result, and finally, you can implant even in the absence of capsular support.
Quick question out here.
I may have missed this, but I'm assuming there isn't a toric version in this lens, and if there was to be one, what are your thoughts about the stability of the lens in the sulcus for toric correction?
Yeah, the question is about toric lens. This has not been tried because so far we had some rotation of the lens. This lens is implanted in the sulcus. The sulcus, you know, that is not warranty circular at all. And this is why ICLs and figure lenses rotate. And this is something that we know. With a new design and with a more rigid design, the rotation has been almost cancelled. This is why we're implanted only one meridian in order to really know what is happening. And the toric lens obviously will come in the future, but it's not available yet. Even that is under investigation. Thank you.
Sorry, just another quick question. Do you think there's variability in the patient's ciliary accommodation? And perhaps the next two talks will be a little bit more towards that, but that would certainly cause some variation in the near gain.
Yeah, you know, any physiological function is different from every one of us. Your biceps and mine are different, so we should expect variability when recovering a visual function such as accommodation. So I'm not surprised, and we were at the beginning surprised because we were expecting more or less what is happening in premium lenses. This is accommodation. Accommodation in a 40-year-old person is different to another 40-year-old person. This is not constant. There is a mean, but there's a standard deviation. And so you should expect variability. In my patients with Illumina, I tell them, listen, you will have excellent computer vision. Near vision will be good for most of the cases. You want to be sure that we have J1 or J2, I cannot promise that. It might be that you need glasses. It's more or less what you say with the advanced EDOF lenses. But this is better because EDOF lenses have halos and glare sometimes, and this lens has not.
Thank you.
Thank you.
Quick question?
What is the IOL formula that you prefer to implant this ACO lens? And any corrections that you would make because the lens is not in the back but it is in the sulcus?
I don't know if I understood your question, doctor. Can you repeat it?
What is the IOL formula or the preferred IOL formula that you would use to implant these lenses, and any correction that you would make, because most of the IOL formulas are for the lenses which are implanted in the back, and now we are implanting in the sulcus. Are there any corrections that you have to do?
Yeah. You know, the IOL is calculated with a proprietary software, so it's not following any of the calculation formulas that are this moment available. You have, in order to guarantee the precision of the calculations, we use only the CASIA as OCT measurement of the different variables that we are involved in the calculation, and second, a proprietary software that is based on a CIMER simulation, you know, on a CIMAX simulation. And the precision is remarkable, you know, because about 82% were plus minus 0.5, which is really outstanding. So in our series, we didn't implant these lenses in patients with more than 2 decades of astigmatism, and of course the standard deviation of the sphere equivalent is a bit more, but the sphere is calculated with a precision of about 0.25, and the industrial precision of the lens is 0.12. 0.12 means more than the average monofocal lenses, the industrial precision. Yep, doctor.
ALIO, very wonderful talk. Just one short question about the complications. Did you meet any intraocular pressure rise, or in your population it's suitable for the Asian because of the shallow anterior chamber eyes, and maybe the anatomy of the sulcus maybe not suitable for this patient to implant the IOL?
Yeah, the sulcus implantation, we use sulcus implantation for phakic lenses, we use for piggyback, and nothing happens, you know. So why it should happen in this lens? Because it is more bulky, true. So we have been following these cases for any pigmentary dispersion out from the first month. There is pigmentary dispersion the first month. Second, because chronic intraocular inflammation or CMA, macular edema. And number 3, because increasing pressure. Neither of the 3 have been happening in the 14 years follow-up from the phase 1 study. So pigment dispersion, pigmentary glaucoma, any chronic inflammation have not been detected in these long-term studies, and the incidence of CMA detected by us has been at this moment 1.2%. So we have all these variables studied and have not been influenced. It's not surprising, because just think how many cases with the ICL develop glaucoma, pigmentary dispersion, or chronic inflammation, and we're implanting these lenses every day.